professor in SMS, but what she doesn't have written here is that she's also the deputy chair for research, faculty development and research, which is a real key role for SMS. And then she has really important roles that are within the, hopefully you all know what CTSA is. It's the clinical and translational science, sort of taking from science from bedside, from bench to bedside to community. And she's obviously the community end of things, co-directing the community engagement core and the director of the implementation science initiative. Her expertise is actually represented in the title. I was going to focus her work is on sustainability in the context of implementation science, and a really increasing focus in the last several years on health equity. So I just was going to tell you a couple of things that I always think is a little interesting in case you don't know at least her academic history. Rachel actually went to the University of Virginia, for the students who are in the room, went to the University of Virginia and majored in sociocultural anthropology, just in case you didn't know that, gives a little lens on that. Went to UNC, and there were two other things I thought were interesting. This is nothing about age. This is about changing names. But the department where she got her master's was called Department of Health Behavior and Health Education, which is now called the Department of Health Behavior. And she got her doctoral degree at Harvard from the Department of Society, Human Development and Health, but that's not called the Department of Social and Behavioral Science. So names do change. I think Virginia is still Virginia, and it's sociocultural anthropology. I just want to say that we worked this, we had to cancel Rachel's presentation 2 times already this year. We tried to find a time for this last year that didn't work out in her busy schedule. And we had APHA at the same time. Rachel had the crazy flu thing that was going on, and we finally have her here today. So I just want to make one note, which is our next food for thought is on March 20th. And it's once a year we have our doctoral students who are progressing in their dissertations present. And so we actually have 3 history students that I think you'd find quite interesting to come and see what their doctoral work is on. That's March 20th. And we have the LitWac lecture in April 24th, which is our departmental lecture by Jess Fanzo, who's a climate and health and ethics person. So have at it, Rachel.
Thank you. Thank you for the introduction. And good to be here with you all. Since this is intimate, I'll probably think here, but hopefully everyone's online. Hear me okay. Oh no, it's not working now. It's okay. It's okay. You have to stand at a certain part. Maybe it like, it's okay. I can come around. It's fine. It's fine. Oh no, now it's frozen. Oh, okay. Let's see if it works out. Never done it. Okay. So a little bit about what I'm going to do today. So I'm going to focus on talking about this idea of sustainability in the context of implementation science, where I focus a lot of my work. And I really am not going to go into the details of my findings, but I want to highlight a little bit about my research journey in this area over the past 14 years and really how that has evolved in terms of my thinking and approach to it. And then we'll hope to talk a little bit about future opportunities to advance work at this intersection of sustainability and health equity more broadly. Okay, a little bit, Anthony already noted this. So a little bit about the intersection of my work and training. So my master's degree at UNC was really focused on community-based participatory research. That is why I went there. I wanted to get trained in that and qualitative research. And then when I did my doctorate at Harvard, I focused more on quantitative and social academia. And a lot of my dissertation work, working with amazing people like David Williams and Nancy Krieger, was really about understanding and documenting how racism and discrimination and medical mistrust impacts cancer screening and cancer. And as oh, okay, cool. Yeah, that better. Yeah, I'll see what she says. Working. And I was doing my work. I finished my dissertation. I was publishing. I was starting my postdoc. But as I was doing all that work, documenting those associations, I started to feel like I was not having impact with my work, especially with my training in CBPR. I felt like I was moving further away from kind of creating change, taking action. And so all of my work, I think now centers on these ideas of community engagement and health equity, but it really wasn't until I started my faculty position in 2010 that I really started to get intrigued and interested in this area of implementation science, which I'm going to be talking about today. And again, part of my interest in the field was the idea that the research to practice gap is hugely influenced by structural inequities. And so I saw this field as potentially having real promise in addressing health inequities. Hi, Bob. And just to kind of highlight some of the fruit of the work I was originally doing. So for my dissertation work, I was working through Dana-Farber Cancer Institute, and I did a lot of what we called at the time life history interviews, these qualitative, in-depth, 2-hour plus interviews among older African American and Latino women, again, to really contextualize and understand differences in cancer screening and adherence to recommended behaviors. And again, my dissertation was really about trying to understand the broader social context in which these behavioral inequities exist, to recognize that there were these structural factors, structural racism as really driving a lot of the medical mistrust that is happening. So this was well-founded mistrust of public health as an institution and as the guidelines. So just to kind of highlight, this is kind of the basis of where I was coming from as I was transitioning to the field of implementation science. And again, this is really important work, and I was excited to be able to contribute to the body of literature that really documented some of these associations and again, help contextualize the roots of some of this medical mistrust. But again, for me, and I actually have continued this work, I've been really fortunate to work with Bruce Link and others on some large cohort studies that have really tracked racism across the life course, financial hardship across the life course, and the implications it has for accelerated aging. So I'm still involved with this work. But again, I want to think about how am I actually bringing this work to create change in the communities that I'm partnering with. Okay, so that again is what brought me to the field of implementation science around 2010. And implementation science, for those that might not be familiar with it, this is really developed in the US context over the last 20 years in recognition of the very well-documented gap between our evidence base, all of the, the funds that we invest in developing and evaluating evidence-based interventions that impact health and health inequities. And then practice, what is actually routinely and equitably delivered in most real-world public health, clinical, and community settings. And we know, I think historically, our approach has been, we just publish, we present at our conferences, we get the evidence out there, we show what works, and that is going to be sufficient. And we know that there's this whole 17-year odyssey to actually get evidence into practice. And I think that we haven't budged much on that. We know that the political and social context has huge implications for our ability to actually implement. So evidence alone is insufficient to create change. So again, this field is all about the idea of translating research to have impact. We can talk about how well we've done that equitably in the field. I put that in parentheses. I don't think that has necessarily been reflected by a lot of the foundations in the field originally. But it's really about the how. What are the methods, the strategies, the frameworks, approaches we can use to promote the more widespread and routine adoption and use of evidence-based intervention into routine practice. And I want to say, sometimes we use this acronym heavy, evidence-based intervention. That can refer to guidelines, practices, programs, interventions, and policy and treatment. Okay, and the field has this distinction between dissemination and implementation. So dissemination is how do we get the evidence into the hands of the key decision makers, right? The directors of the clinics, the principals of the high school, the people who have the power to say, yes, we're going to take on this program or practice. And then implementation is have the buy-in. How are we actually going to get it integrated into the setting and the system and people trained and ready to use? I would say 95% of the field has focused on implementation. We have done very little with dissemination. There has been some important work on policy dissemination, but this is a huge gap. So when I came to the field, I said, okay, we're thinking about this for 6 months, this first year of implementation. What happens long term? What happens after a year? What happens after 5 years? where does sustainability fit into the field? And as you can see here, we think about the traditional translational pipeline and the research continuum. Sustainability or sustainment is tucked in there as the very last phase. And that's the reality of what's happened. Even with the best intentions, we often don't get to it, right? We run out of time in our research study. Really tough to do the study as well for lots of reasons that we can talk about methodologically. So it's been a huge, critically important, but hugely understudied area. And I also believe it's not a surprise that we have challenges in sustaining evidence-based interventions in these settings if we are not thinking about it until the end, right? We have to actively be thinking about, are these interventions sustainable? And we can't also wait till the end to be thinking about issues of engagement and equity, right? There's been a huge disconnect between our evidence base and the populations and settings represented in clinical trials and randomized controlled trials that define our evidence base. And then the real world settings where huge structural inequalities exist. And so we really, again, have to be understanding the context of the settings and making sure that we're representing the perspectives of the communities and settings and populations that experience inequities if we want to have an impact on long-term sustainability in those communities. When we look at the literature, you can see, again, sustainability has been very understudied. An analysis at NIH suggests only 3% of studies have focused on sustainability. We did a review of 10,000 articles in public health journals and 1.3%. So again, if you're looking for a dissertation topic or an area to invest, huge, huge gaps. In our work, this is a paper I had the opportunity to write with MPH students in my class in 2018. And we had really tried to make the case that if we want to advance the science of sustainability, we can't squeeze it in with implementation. We can't think about it only in that first 6 months or year. We need to be thinking about longer time frames and really advance the science as its own domain, related to implementation, but distinct. Okay. So we have put forth this idea that if we want to have impact and create lasting transformational systems or structural change through implementation science and create the conditions for health equity, which is a tall order, we must prioritize and advance the science of sustainability. Okay, so why do we care about this? So, you know, we all work on important different public health issues. No matter the public health issue, no matter the setting, no matter the population, sustainability is a huge, well-documented. One of my mentors was Marian Shire, who was a pioneer. She actually did her dissertation in the 70s on sustainability, and she was a program officer at the Robert Wood Johnson Foundation, and she did an analysis of all of her health promotion and public health funded interventions through Robert Wood Johnson Foundation, and she found only about half of the program sustained one component 1 to 6 years later. And research since then has really documented this notion that only about 40 to 50% of interventions are sustained a year or more over time. So again, huge discontinuation and loss of resources. And I think this is really important for us in public health in terms of issues of accountability, right? NIH, the public invests, you know, in our science, invests in us to fund these evidence-based programs. When you look at the budget of NIH, that is a lot of where the money is going, the development of treatments and programs and practices. So we have this investment, but then they're not sustained, right? There's really this issue of accountability of why we're not having that. And if you've been involved in an implementation effort, you know, implementation of a new program or practice in a setting, you know the amount of time that the investment of practitioners, provider, patients potentially. And so I think that the lack of continuation of programs also creates frustration, right, of that lost time, and also weariness and mistrust of researchers and of public health institutions, right? So even if it wasn't our research effort, we are kind of reinforcing some of that mistrust with communities when those programs are not invested. So huge issue, and again, I think in terms of health and equity, It's one of the most complex but pressing issues. And additionally, you know, and that's we really care about broader social impact as well. And when we think about the translational science benefits, you know, that we want to have in terms of community change, in terms of economic change, in terms of policy change, we have to be sustaining interventions to have impact that's happening at this scale. Okay. So in terms of my work, I have really tried to define conceptualize sustainability as really being multidimensional. When I went to the literature in 2010 and looked back at how people have talked about this concept, it was almost always synonymous with this notion of institutionalization. You know, if you just get this program or practice or policy scrutinized into the budget line items or into the clinical workflow, that will be. And I think there's been a move away from thinking about sustainability as just being about institutionalization, because we know that our contexts are really dynamic, right? So we have tried to capture multiple aspects. So it's really about the extent to which there's continued delivery of the original evidence-based intervention or practice. We often talk about the core components of a program and how it's adapted over time. The extent to which it continues to have health impact on the behaviors or outcomes that we're studying and how it might reduce or exacerbate health inequities, as well as the extent to whatever partnerships or networks or coalitions were built in order to sustain our continued as well. So again, we think about it with these 4 domains, but honestly, a lot of people focus on this first one and sometimes don't. And again, this is really consistent with the broader literature now and how the field is thinking about this. This idea that sustainability is not this static end goal that we're trying to reach, that we're going to get to in 2 years, right? That it's much more dynamic. It's about understanding change and impact and needs. So this notion that things don't need to be static and that we may need to evolve and adapt intervention or program or practice to fit changing. I really credit David Chambers, who leads the Implementation Science Institute at NCI, for really shifting the field about 10 years ago and thinking about this. When implementation science was first developed, it was highly focused on the clinical and healthcare. So a lot about medication treatment, cognitive behavioral therapy, not these complex social interventions we have. And there was a really strong focus on this idea of strict fidelity to the intervention at all costs. And I think this notion of dynamic sustainability has evolved to really reflect that, you know, our contexts are dynamic. Look how much our systems and context changed during COVID, right? Our evidence base is also not static. Our guidelines change, our science evolves, and our community needs are not static as well. So really thinking about sustainability and continued delivery over time as a learning opportunity in terms of understanding what changes need to happen over time to enhance their fit, again, with these changing evidence, changing context, and changing. The other thing we put forward in the field is this idea, again, that we can't wait to think about sustainability, right? Especially if we want to have impact on health equity, we have to be actively designing our interventions, planning for sustainability. And again, there's been a huge disconnect in the field between our evidence base and our planning for sustainability and our work on in implementation science. So again, we've made the case that we need to actively understand across these earlier phases, what are the interventions that have the potential for sustainability? What are the factors that matter, not just for that initial implementation, but for that long term? So really thinking about and understanding that earlier in the translation. When I went to the literature in 2010, I could find very little about the different sustainability. And a lot of the work would say, do retrospective studies, and they would say, contact one person at the organization and say, was this program sustained, yes or no? So it didn't capture the extent of sustainability. You know, it was retrospective. There were a lot of issues with it. And there was also this assumption that the only thing that mattered for sustainability was funding and resources. And we know that matters, but often funding alone is not sufficient. And there are sometimes other factors that can compensate. And so now there's much more, we've helped develop a much broader literature that considers, these other determinants of sustainability, how it aligns with policies, financing, partnerships, and political and social context, how it aligns with the organizational context, the extent to which the characteristics of the intervention, its adaptability, cost, are aligned with sustainability, and characteristics of the population and the implementers themselves. So now we're starting to build an evidence base to understand what might matter for sustainability. And I often get challenged by my colleagues in the field saying, what matters for implementation is probably the same stuff that matters for sustainability. What is possibly different? It's just longer term time frame. And I really try to make the case that, in changing context, there's a changing policy context. There's changing leadership and leadership priorities. When a new person comes in, they often want to remove existing programs and have kind of their own stamp on things, right? There are changing financial needs, and we often are thinking very short term, year to year, with our investments. We also often don't think about one of the biggest challenges of sustainability, which is turnover of staff, of leadership. This is time and time again, issues of attrition and organizational stability are the most key predictors. So again, we have really tried to build the evidence base of the conceptualization that there might be additional factors that we need to consider. Oh, it's warm in here. For those of you online, I hope you're somewhere cooler.
Oh, stand by the air con.
Okay. Okay, so now I'll get a little bit into my work on sustainability. So that's a bit about what the area is and how we've approached it. So as I mentioned, I was finishing up my doctorate and postdoc, doing all this descriptive work. And again, I met with my mentor and I said, I don't want to start from scratch. Are there already evidence-based programs that are out there that are addressing some of these social and temporal determinants that I'm studying, right? That are already having an impact on cancer inequities. And she partnered me with this group called the National Witness Project. There was a site in Harlem that was based at Mount Sinai where I was doing my postdoc. And so she said, I'll connect you to this group. I don't know if they'll be interested in working with you, but they have been in place for 20 years now. Nationally, they've been nationally disseminated. They're an evidence-based program, a peer-led evidence-based program for cancer screening. And so I met with them. I had all these ideas about we could study social capital, we can study the impact this is having on your communities. And they said, that's great. We're not interested in that. We only care about issues of sustainability. They have lost about half of their programs. They've gone from 40 programs nationally across the country to 20 programs, right around the economic downturn in 2008. They said, if we partner and write a grant with you, we want it to focus on sustainability. So we did. And surprisingly, we got our first grant funded the first time in. And this was us, right when it was funded. It was a 2-year NCI grant, and we had a big meeting in Florida to celebrate. So I think I was newly pregnant on the ground. And so this was really what we launched together. Again, this was really driven by them. I really came to the field because they wanted to have answers to the issue of sustainability. So a little bit about this program. So this is an amazing, amazing program. They are one of NCI's evidence-based cancer prevention control programs. They're kind of a gold standard for community-based programs. Basically, they are both African-American women, about half of whom are cancer survivors themselves, about half who are labeled advisors, trained in the community. And they really deliver everything from education to navigation, support, to helping identify insurance, to providing testimonials about their own experience. And they address a lot of issues, social contextual factors around mistrust, stigma, and discrimination. And originally they were highly faith-based. There's a lot of those components, and many of them were based originally in churches. But when they were nationally disseminated through the CDC around 2000, almost all of them ended up having homes in academic or medical centers or schools of public that they were hosting. So this program, again, at this point has been in place over 30 years, disseminated with 40 sites, and has had huge impact. It screens and reaches over 15,000 women per year. But again, despite the fact that I think they're an exemplar for sustainability, which have been in place this long, there are huge challenges again that they face. So when we got this grant, we first again wanted to say, what's the, who are these women? When we look at the literature, we find nothing about the characteristics of women who are lay health advisors in their community. Nothing about their motivations to be in the role or what keeps them. So this was important to them because they were having huge issues with attrition. They also wanted to understand, again, what keeps them in the program, and then what are the factors that impact the sustainability of the programs more broadly. So this was a small NCI grant, 2 years, short term, 8 sites, and we had 76 lay health advisors and leadership. So just to show you kind of high level what we did. So these are the original founders of the program. I just want to highlight Ms. Maddie and others. This is from the early 90s where the first program started in Little Rock. So the first thing we did was just understand the characteristics of these women and really captured, when I went to the literature, the only thing I could find was information about the health outcomes of participants who attended these. So we really wanted to document, what brings women to these roles in terms of their own experiences of discrimination, their own personal experiences with cancer. And then what do they get out of it in terms of their own capacity and career development, which we learned about, in terms of their networks. Many of these women, especially the cancer survivors, talked about the value of the social network for them, particularly as they were going through recurrences and a lot of health issues. So hugely supportive. And then we also want to understand the organizational level that are happening at Spill and more broadly in their. So we put this out as kind of a broader conceptualization of the impact that these have at the organizational and social level and in their. Then we wanted to look at and follow a group of lay health advisors from this program. So we looked at all these factors we just talked about, all the things that we heard about in terms of what brought them to the field, to this program, what they said kept them in it. And then we want to say, okay, look at all these individual factors, social factors, and organizational factors, and we'll see which ones predict the extent to which women remain in the program over time as lay health advisors. And we really thought it would be those social factors, since we'd heard that in the qualitative data. But what we found is there was no variation in that. All of them experienced that social benefit. But what was different really was the organizational setting in which they were supported or not. So we found that organizational factors were the biggest predictor of whether or not lay advisors remained in the role over time. And we found that lay health advisors that were at sites that had strong academic, public, or health partners were 80% more likely to remain. So we went back, did some qualitative research to say, what's happening at these sites that's different? And we found that they had regular trainings to kind of keep social cohesion and learning. They also importantly covered the financial gap. So a lot of these programs were supported by short-term stipend, year-to-year short-term funding. So the academic partners would cover some of the financial gaps and resources, and they provided a lot of organizational infrastructure, right? Things like space, printers, things we really take for granted. So for us, and a lesson that the program really institutionalized across the country was, first of all, we can't just have a one-time training if the hope do so well. They instituted nationwide national training for them to both reinforce learning and advance career advancement, but also the social cohesion. And they also said, you know what? It's not enough that we have these community champions. We really need to be identifying academic and health, which they tried to do, not always with great success, unfortunately. The other thing we did was, that was kind of our quantitative work. And in the qualitative, we really wanted to unpack to understand what else were we missing? What else did they think was important for sustainability? So again, we took a lot of the broader implementation frameworks and thought about kind of the policy domain, the organizational domain, all those characteristics we just talked about, and trying to kind of say, what else are we missing? And how is this being sustained? We understood much more about the how and the why of sustainability at these sites. So just as one example, we were really able to operationalize, like I just described, how they were accessing resources through these academic and public health partnerships, right? We were also able to really hear much more about their experiences of institutional racism and discrimination within academic and healthcare settings. Interestingly, when we started this work, 7 out of 8 of the sites were all housed in healthcare and public health institutions. And over the course of the study, all but one had left and became standalone community organizations, either because of funding cuts, lack of prioritization of issues of health equity, and what they felt was a real disvaluing of African-American women leadership and the contribution of their program. So all of them became standalone programs. Some of them kept those partnerships, but they did not feel like they had an organizational home for support within a lot of them. Okay, so that gives you some insight into kind of the approach we took. And again, we did that for each of the levels. So what we did then was identify all these potential barriers, right? In terms of funding, in terms of, again, their experience with the fit in the organization, in terms of the limited training, the lack of valuing, as well as the facilitators, right? This program is really unique. It was developed by and for African-American women. It has a really powerful role in cancer survivors. So there were also a lot of strengths in terms of what kept the program going. What we did is we created what we call the Lay Health Advisor Conceptual Framework. We had a 5-year gap in funding, I will say. So from 2013 to 2018, we tried to keep our partnership going. It was really hard to get work on sustainability funded. But we finally got this work funded by the American Cancer Society in 2018 to actually test this out. You know, not all of these factors can matter. This is what we learned about. It was qualitative and really comprehensive. But we wanted to say, okay, over time, over the next 5 years, at all the sites across the country, which of these factors are going to matter? So this was funded in 2018, and we just wrapped up last year. And I can write up a book about doing a sustainability study during COVID. It's really hard. But we really, we had an amazing learning experience, I think, for the study. So you can see we had actually all 16 sites across the country participate, and they all had varying levels of sustainability. But you can see nice geographic representation, and we had 201 participants, both lay health advisors and project directors at the site, and 3 waves of data. In terms of outcomes, like I mentioned, we both tracked annually all the sustainability indicators in terms of, you know, number of programs they were having, number of women reached the screen, institutional indicators, etc. So we looked at, again, multidimensional statement outcomes. And then we really grouped the sites. We found that there were some really clear patterns at sites in terms of higher sustained sites over time, moderate or variable sustained, and ones that were completely inactive or low active. And so we did a bit of a comparative case study when we grouped these to see what were the factors that matter across these different groupings. So again, what we found, perhaps not surprisingly, was it was really the outer contextual. Again, these organizational partnerships, the fit with the organizational home, the partnerships, the nature of funding, the valuing again of the program. These had huge implications for, again, their organizational support, right? Their day-to-day resources, their physical space, their ability to have leadership teams and champions. So again, we found these were really the key drivers of sustainability over time. So again, this really reinforced our earlier work that sustained partnerships with academic, healthcare, and community settings are critical for sustainability and really facilitating access to a lot of the resources, social connection, and funding. And again, the critical importance of the alignment, both at the funding level, as well as at the organizational setting level, in terms of having that support and feeling respected. Again, the need for ongoing training for all those reasons. And then another thing we learned about during COVID was, again, this nature of dynamic sustainability. How the sites that were able to adapt and address the social needs during COVID were actually the ones that were able to sustain. And so what we found is that during COVID, women weren't getting mammograms, as we know. Huge issues in terms of accessing screening. And the program realized we can't even talk about mammograms without addressing issues of food insecurity, housing insecurity. They got political and they were doing voter turnout. They completely shifted their model, the sites that sustained and created whole new partnerships. And they said, once we have this in place, then we can talk about screening and navigation. So it was really a game changer for them in conceptualizing the program. And I think this kind of reflects it, since the pandemic started, the needs of people have become amplified. And we've been reflecting on the care we provide and make sure we don't participate in inequities and make sure we create racial justice while we're also doing health justice. So really talking about how, of course, screening is so important, but it happens in the broader context of these other social needs that have to go hand in hand. The other thing that we really shifted during this time, at the end of each year or each study with them, I would provide summaries, I would come visit and kind of give the highlights. But during COVID, they said, no, we want all the data and we want all the data every year. So we really shifted our model in terms of being really accountable. We've actually done more with the data with them than we have with a lot of it we haven't published. But they each site wanted a summary of all their data year to year in terms of capacity, de-identified, and then the overall site reports. I'm actually, after this, giving a board report to them on the final data. And so they wanted it, and they said, this is so valuable for us. We can use this data for grant writing. This is valuable for us to make the case. So really that accountability for us of returning the data has been a really critical element of our partnership and trust. And as you can see, during COVID, we kind of captured a lot of the components of determinants of sustainability using existing measures. And, higher is better. You can see in that first year, they were much higher. And during COVID, all the sites uniformly really struggled with, so all of them have been kind of rebuilding things. Okay. The other thing we've been doing is in implementation side, so much time is spent on implementation strategies and those. Things like training, audit, feedback, addressing all those implementation barriers, but no one has talked about strategies for sustainability. And so we thought, can we match all those issues that we've talked about with the partnerships, with the trust, with the funding, lack of funding stability, with the need to adapt the program, and can we think about specific strategies that we could test to promote sustainability? So in the last year of our study, we really worked with all of 15 sites and got data on what they thought would be both effective and feasible strategies for sustainability. And again, it maps onto a lot of the things we've been talking about in terms of building partnerships, building the business case for the program, expanding the program to address social needs. And hopefully April 1st, we put in our follow-up grant last June, and amazingly, it got 3rd percentile the first time in. Never happened to me, but it was really clear, I think we made a really compelling case that the next step is to really think about testing these sustainability strategies. And what was so cool is that the head of Witness, this amazing woman in the community, had just been through NSF's program on for researchers and on what they call it, the Sprint commercialization program, where it basically teaches you to commercialize your research. And she had been through it as someone who works at Roswell Cancer Institute. And as a result of that, she was able to take the program in Buffalo, where they were based, and form a partner with Mokila, the insurance agency, where they did a contract across the entire state to cover the time of the health advisors to be able to navigate for breast, cervical, and colon. So again, she said, through these lessons, we need to take these lessons to all of the community sites, right? And so part of our vision is in the first year of the grant, we're going to work with the sites to think about how do we adapt this curriculum and this program and building the partnerships and the business case for community partners, not for researchers. So that's what we're going to do. And then really develop and test the strategies of the curriculum and the community of practice that we develop across the site in the next 5 years. So, okay. The other thing I want to touch on is the issue of de-implementation, which has been hugely important in the context of this study. So de-implementation is, this happens a lot in the context of sustainability, that your evidence base might change over time, right? And that you might actually need to remove or adapt a program to reflect new guidelines. So this is extremely common at the time, but there's been very little work on this. And this is what's happened in the past 30 years with witness. The cancer, the breast and cervical cancer guidelines have changed multiple times, right? Even recently, in terms of the age of screening, in terms of the interval, in terms of whether or not breast self-exam is recommended. It's a huge cornerstone. So again, what we do is a part of our grant was to understand years ago the extent to which programs were adapting to stay evidence-based or not, and why. And what did we find? So when I went to all the de-implementation models in the literature, all of them, focused on things like organizational context, fit, attitudes, knowledge of the guidelines. The women had all of that. They knew the guidelines, right? They knew what they were. What wasn't represented was this notion of trust. So we added issues of trust, and we found, again, not only was there not high levels of trust of providers, but as you can see, the leadership, the project directors, less than half trusted the new guidelines that had come out. So many of them were not adapting the program, not because they didn't know, but because they felt like the new guidelines did not reflect their own personal values and also the experiences of African Americans. They talk about how the guidelines were really informed by women, data from white women. And this has been a real issue because African American women have higher proportional incidence of breast cancer and more aggressive tumors at younger ages. So they said, for us, we're not going to wait to start screening at 45 and 50 when most people in the African American community get cancer rate and birth. So this was hugely important. And then this perception that, which actually happened, we're just going to change the guidelines again. We're going to educate women, get them on board, and then it's going to go back. And then they're not going to trust us. So again, this changing guidelines and this issue of trust was hugely important. And then again, this belief that the breast self-exam and the testimonials of the cancer survivors, the narratives, is such an important part of this program. And they were now coming and saying, we can't talk about breast self-exam anymore. And this was, again, a deep core belief in terms of the importance of this. And that they felt was kind of being taken away. So they actually had to go to NCI to remain an evidence-based program and make the scientific case for why they can keep breast self-exam in the program. And they argued that they won't use it as kind of screening. They know it's not going to impact potentially mortality, but that it's an educational and empowerment tool for African-American women to be in touch with their bodies, and potentially because many of them might not be accessing or have access to mammography screening. So they made the case that that was particularly critical and great. And we actually, this is Dee, who leads the National Witness Project. And we had the opportunity to actually present this at National Academies of Medicine last July, to really kind of make this case that, our guidelines, if they don't reflect the experiences of populations that experience structural inequities, they're not going to be trusted, right? We're going to have low uptake of guidelines if we're not making sure that that original evidence base does not reflect the experiences and values and realities of those populations. And I am, often reminded how disempowering it can be. They tell me when we kind of swoop in and say, oh, we have a new program, we have a new guideline, here's the latest, get in line. And, again, contextualize why there is that mistrust of the guidelines. And I think for me, it's really helped me contextualize that, but also think about the benefits and harms and the consequences of that when we're trying to make changes to programs. Okay. As a result of that, we have continued to do work on the implementation. I just want to highlight a grant that Natalie Moyes and Teresa Tranafar and I have that's really trying to understand better this issue of the implementation and some of the challenges from the patient perspective when they're perceived as having something taken away, and some of the issues that unintended consequences I think that can happen with inequities around that and trust with that. And so we're looking at that as a patient, provider, and citizen. So thank you. Maybe the next. Okay, so I want to make sure I have time to wrap up. So big picture, there has been, I believe, excitingly, a lot of advancements in the field of implementation science. I put some of the annual review of health work that we've done, text chapters, and a lot of collaborations in the last 14 years in this area. I think we're at a really important time for the field where there's finally some consensus around the definition, the frameworks. There's the opportunity to actually think about, again, testing this in different settings, thinking about sustainability strategies. And then again, really making the case for the return on investment of sustainability. Why do we do this? It's like we're always having to do a public health making the case for benefit. It's quite similar, but I think again, huge implications for health. In my own work, we have developed kind of a more broad sustainability framework. We did a review of about 300 articles in literature and tried to identify across a range of types of clinical, community health, and global settings, some of the common factors that matter. And then what we've been doing is partnering with people in a lot of different settings and contexts to refine this. So we have a qualitative guide in the textbook, the practical application science textbook that maps on. And I've been so excited to work with colleagues. Juliet is actually giving a talk on Friday through our CTSA interested. Adam Smith and colleagues in Australia. So we've really been now refining testing to understand the specific factors that matter for sustainability across different settings. And we have also taken the implementation science strategy toolkit, which has 72 strategies. How many? And we did a bit of a concept analysis with our partners in Australia to say, do all of these actually map onto sustainability? What might we need to add? What's missing? How might we frame some of these? And so we published this last year, and we just got a grant funded with colleagues in Australia, following a global sustainability consortium to kind of test these across 150 schools in Australia. I'm excited about this. And then the other part I've been really excited about is measuring. Thinking about actually being really accountable and actually tracking sustainability and health equity. And so you might be familiar with REAIM. It's one of the most common evaluation and planning frameworks in public health. And so I had this aha moment as I was about to get on a plane to Australia, and I was like, I want to say more about measuring sustainability and health equity, but I don't want to put another framework out there. There's already almost 300 frameworks and implementation science. And so I wrote Russ Glasgow and I said, would you be willing to talk to me and think about how we can extend this framework to have a greater focus on sustainability and equity? And to me, just the general, like the fact he even responded to me, but we kind of took that and have extended it now. And so the traditional way we think about issues of adoption, at the setting level, reach, implementation, effectiveness, and maintenance is usually we get to the end and we say, oh, this wasn't sustained, there were huge inequities, but we often don't know when and where along that continuum. Was it the extent of implementation? Was it the adoption at the site level? Was it the individual patient impact? So again, we want to make that really explicit. And so we reworked the model with a greater focus on equity and again, much longer term sustainability. So thinking about iterative evaluation, a year, 2 years, 3 years down the road. And again, understanding, not just tracking this, but then saying, okay, what do we need to actually adapt with our interventions to address these gaps? And we reworked all of the VA interventions, again, with a greater focus on both health equity and sustainability. This is published if you're interested, but this has been amazing to kind of have this idea, put it out there, and now working with a lot of implementation science centers across the country to kind of operationalize. And then lastly, have also worked a lot with Maji Halmarian and Juliet again, who's presenting Friday on Nigeria. To again, really be more explicit about thinking about why sustainability is a health equity issue and how we might address some of the gaps in terms of planning, being more accountable, and engaging with partners too. One thing that's been a real challenge for me, this sounds like a nice, pretty story of all the grants that came in and successes, but this is really sustainability and issues of health equity are very difficult to study in the context of research environment, academic environment. We had, again, huge gaps of 5 to 6 years where we didn't have funding to support our partnerships. And it's been really difficult even to get partners on as PIs to think about cost sharing of resources and decision-making in the context of NIH grants has been a challenge. And so I think that we have to recognize that this work requires as well some shifts kind of in academia and our funding structures. Okay, the last thing I'm going to say, I'm going to wrap up. Okay. In parallel to doing all this work, 5 years ago, I was asked by NCI at a meeting of 250 people if myself and a colleague would summarize in 5 minutes the entire literature on health equity and context and implementation. And so, so for me, like as I've been doing this work on sustainability and had this focus on health equity, this was also happening. Because when we did this deep dive into the literature, we found that health equity was kind of everywhere and nowhere in the field. You know, so many of us came to the field to address equities, but when you looked at the frameworks, there's no one's talking about power or racism or discrimination or stigma, right? It's been completely missing in terms of our frameworks, our interventions and strategies. And so since 2018, a group of us have really been working, what would it look like and mean and to have a more foundational focus on health equity and implementation science for all the foundations, not as a tag-on, as a special issue area, but really as foundational. And so in 2019, David Williams had a call for a special issue on structural racism. So coming out of that working group in 2018, we said, we have to put this out that no one is even mentioning the word structural racism or power in the field. And we need to kind of we had a big picture kind of call to the field that was a couple thousand words where we wrote about this that was published in 2021. And we made the case again of why does it matter for implementation science? And again, you know, structural racism does not just shape the health inequities, it shapes the research practice that, right? So residential segregation is shaped which neighborhoods, which areas have access to high quality evidence-based interventions or the organizational resources and infrastructure. So again, it is a fundamental part of the research to practice gap and how we practice our science in terms of what we've identified as evidence base, right? Who gets to decide what the evidence base is, who is reflected in the evidence base that we're in. So part of our follow-up to this was in 2020, when all of a sudden all these implementation scientists were saying, oh my gosh, we have to address health equity. What are we doing around structural racism? We said, okay, wait, there are 30 to 40 years of work outside of our field that has been doing really important work on structural racism. We do not need to recreate the field, but we need to partner and think about how this applies to implementation science. So Projecta and at Sewell in April, O and I had written a commentary on structural racism. I've worked with Derek Griffith for about 15 years now. He directs the Racial Justice Institute at Georgetown. And he's done a lot of work on anti-racism and public health. And then Natalie Noyes, my colleague, we lead the implementation science initiative here at the CTSA. So we got together and said, what would it mean and look like to apply an anti-racism framework to all the foundations of implementation science? So we worked together during COVID. We met every couple of weeks and wrote a paper together here on the bottom left that really called for rethinking everything from how we go about community engagement to how we think about context in our frameworks, how we select what counts as evidence for our interventions, how we're evaluating, and what our strategies are. So really thinking about framing all of this with the focus on anti-racism. And again, a lot of this was shaped by the work that Derek has done and Chandra and others in terms of public health, critical race practice. So that to me has been exciting. It's an exciting time for the field because I think there is receptivity and openness to this idea. And there's recognition that wait, we don't need to create the wheel, and we have a lot to learn and partner with in implementation science outside of our field. And whose voices are we amplifying in terms of that work? So that has been really some of the most important work that I've been excited about. Okay, I'm gonna go to the end. This is the article, if you're interested, is in implementation science research and practice. And we go through all of those different levels, and we both are critical about how implementation science has addressed each of these issues. And then we make recommendations and kind of have reflection questions on how could this look different. Okay. Go to the end.
She had a record number. of
So
slides.
many slides. I always have so many. And I think the most important thing for me, as I work in a lot of these large scale implementation trials, has also been making sure we're not forcing health inequities to do a lot of our implementation science work. When you look now at what we're publishing, you know, in the implementation science journals, again, it's often a lot of the most resourced settings and populations. So I think as we think about what we're funding and supporting, we really have to be thinking about issues of reach and representation so that we ourselves are not recreating, again, some of these inequities and precedents. And we have a new grant, new UPC4, where we're testing out some of these ideas globally with partners in South Africa. And I'm really excited about this phase as well. Okay, I really am going to say thank you to the witness partners. They are amazing. And my colleagues in the global sustainability and also. Thank you, my funders. My question. Yeah.
That was, I'm so glad I took the come.
Yeah.
I have lots of questions, but a quick question about just sort of the learning you did during COVID, which understandably was complicated.
Yeah.
Do you think, if COVID hadn't happened, you would have different things would